Good afternoon, everyone. Thanks for coming to the Iridex Speakers Forum. I'm Joan Stauffer, and I manage our clinical education programs. And I'm pleased to introduce Dr. Murphy, who will share his experiences using our IQ577. Dr. Murphy. Thank you.
Okay, thank you very much, Joan. First, I know a number of you here, you know I'm a clinician, I'm not a basic scientist, so we're not going to talk about PDGF and VEGF. We're going to talk about the clinical use of lasers and our travel with our journey with these lasers over the last 20 or 30 years. I think the goal over that period of time has been to try to achieve the magic holy grail of laserology. That is, to get the desired clinical effect and to minimize the adverse effects, to get the vision back, to get good vision, to achieve as good a vision as possible, and minimizing the adverse tissue effect and minimizing the collateral damage. So the subtitle of the talk is borrowed from Monty Python. Lasers aren't dead yet by any means. There's been kind of a quietus in development of and experimentation with lasers, but I think that period is over and we're coming into an interesting new area of lasers. I'd like to thank Giorgio Doran and Ted Budikoff for the technical assistance with this talk, and also I'd like to emphasize it's going to be a little bit about the history of lasers and yellow lasers, and the emphasis obviously is going to be in what's so special about 577, and talking specifically about some of the features of the IQ577, and a topic close to my heart, which is micropulsing of lasers. So just before the talk, Ted asked me, well, he's so cute. He said, what do you think about this laser? What am I supposed to say to Ted here at the Iridex forum here? So I said, well, the bottom line is they work really well. You get less tissue damage. You're able to use shorter burns, shorter durations, smaller spots, lower power, which translates to more patient comfort. The patients are happier, the doctors are happier, and treatments take less time, so what's not to like about them? But if we go back about 25 years, the first retinal photocoagulation with 577 yellow laser light was performed by my good friend Rosario Brancato in 1975 with a flash pump dye laser. A single pulse outbeam beam was tunable over the fluorescent spectrum of rhodamine green dye, which is 560 to 630, and delivered to the retina via direct ophthalmoscope. The clinical observations, even way back then, confirmed the theoretical predictions that the 577 wavelength was an ideal wavelength for retinal photocoagulation for the following characteristics. So the first retinal photocoagulation with the continuous wavelength 577 was via slit lamp, was performed in 1983 with a hybrid coherent 910 Argon laser photocoagulator. And under Rosario's supervision at the University of Milan, it optically pumped an external continuous wavelength jet stream dye laser coherent model usable over the fluorescent spectrum of organic dye rhodamine green. So during this time, after this time, as the laser development progressed, the most frequently wavelengths used were green, used for most applications. And at that time, they had higher power, but they tended to make pretty dense, harsh burns that translated into laser scars, and some of those laser scars would spread. Over the next decades, some yellow lasers became available, but they were only available from argon dye lasers, and they had limited power, and they were fussy. They deteriorated over time, and of course, we also had red lasers then too. The clear advantage of the 577 wavelengths was the ability to produce a visible burn with markedly less power than with the blue-green laser wavelengths, and with less collateral damage. Up to 50% less power was needed for intended laser treatment endpoints with this 577 yellow compared to blue or blue-green. And this translates into less patient discomfort, less axial and lateral thermal spread, less anatomical and functional damage, and less progressively enlarging scars. Remember, our goal is to try to get the job done, but with the least amount of tissue damage and the least amount of scarring, and the less is better. So gradual obsolescence of the gas ion lasers reduced interest in yellow laser photocoagulation for a decade or so, but it was resurrected shortly after that with a 561 solid state frequency double green-yellow laser. But it's really the Iridex company that came to the forefront in the last couple of years, when in 2006 they introduced the IQ577. It's the first ophthalmic photocoagulator incorporating a frequency doubled solid state laser capable of delivering up to 2 watts of power at the critical 577 wavelength, which means that you can use it for anterior segment applications as well as posterior segment applications. And it's stable and reliable and has some tremendous advantages that we'll see. Faster treatments, smaller lesions, more controllable, reproducible, and lighter burns, and none of the inconveniences associated with the previous argon dye laser photocoagulator. I mean, it's like too good to be true. But for many, many years, physicians have commented that they appreciated 577 for less scatter, increased efficiency, and less pain. And as Marty Mainster so nicely said, that there's very little absorption by the xanthophyll pigments, but nice absorption by oxyhemoglobin and deoxyhemoglobin, and good absorption across the spectrum with melanin. So retinal photocoagulation with the 577 is characterized by the highest oxyhemoglobin absorption, the highest oxyhemoglobin melanin absorption ratio, negligible uptake by macular pigments including xanthophyll, lower phototoxicity, lower scatter, lower power, and excellent visibility of early light tissue reactions. And we'll talk about that a little bit later. So what's so special about 577? Part of it is you get higher absorption at the target, which translates into the containment, the confinement of the laser energy and a smaller area of tissue with less collateral thermal effects. And you have readily observable tissue reactions with constant contrast. So you can see the burns better and you can see them appearing better. We'll talk about that in a minute. Higher absorption in oxyhemoglobin leads to superior intraluminal photothermal efficiency in vascular structures such as the chora capillaris and the choroid. More efficient laser heat conversion in the retinal RPE complex, the chora capillaris complex, is due to lower scattering into smaller spots with higher irradiance at the RPE level. So that's another clear advantage. Moreover, there's greater cumulative absorption in the melanin oxyhemoglobin layers of the RPE chora capillaris complex as well, with lower absorption by macular xanthophyll. Now, I started using the laser about a year ago, and it occurred to me, my goodness gracious, we're seeing, especially with focal laser treatment in the macula, the laser burns would appear almost instantly. Like before, you'd put a laser spot in and wait some microseconds, and then gradually a glowing burn would apply. But with the 577, you just push on the foot pedal, and bing, a little burn would be there. And it was so subtle at first I didn't realize it. I realized something was better about the laser, but I figured it was the optics or maybe the optical system or something. And so I was discussing this with Giorgio at Arvo, and it's a true observation. You can replicate it when you do focal laser treatment in the macula. You can see these little laser burns, the laser tissue interaction of the tissue that translates into a coagulation effect almost instantly with the laser, whereas you couldn't with the blue-green or the green, even the green lasers. And Giorgio will be here after the session to explain the physics of this. But briefly, the optical characteristics of the protective filter allows the visibility of the initial burn development represented by the blue-green scattering increase at the RPE level. And using green lasers, this early tissue reaction is mostly obscured by both the green protective filter and light scatter. And so the surgeon normally would see the blanching endpoint only when the overlying inner retina started scattering the white illuminational light. So it's the filters that allow you to see more precisely that earliest sign of the retinal burn, which is a very powerful tool when you're interested in reducing the excessive laser tissue interaction. In addition, the possibility of suppressing the confounding glare of the red aiming beam during the laser firing as well helps a lot. So there's a lot less scattering too. There's no question that the green scatters more, as you can see in this schema. And I think, did the yellow come on there? So compared to the green scatter with the yellow, it's a much more precise, localized burn. So what you see is what you get. And you don't get so much of this blooming that we're used to seeing even with the green laser. And that again is a much more powerful advantage when your goal is to make smaller, lighter, just threshold burns. There's less pain. The patients are more comfortable. And the patients will tell you that. It's really interesting when they're used to having a lot of treatment on the green laser and then you treat them with the yellow laser and then the nasty people at Iridex take the yellow laser away from us because they have to bring it to the academy, and you have to go back to the green laser. The patients will complain that old laser hurts. I want to use the laser that doesn't hurt. And that's because the pain depends on the wavelength, which is absorption, the power setting. You can reduce the power because it's a more efficient laser, less scattering, and also because you're seeing that first visible effect sooner than you would with the other lasers. You have a shorter pulse duration. You can turn the power down and less scatter because you can turn the spot size down. For example, in doing PRP, you can turn the power down to 0.07 seconds and or the time down to 0.07 seconds, 0.07 seconds, 7/100ths of a second, which allows you to turn the power down often to less than 200 milliwatts. With a 500 micron spot size doing your PRP, still got a nice little PRP burn that's not going to spread, it's not going to form heavy pigmentation, and for the patients, it's a much more comfortable burn. It doesn't hurt them. It's almost like general anesthesia. And then again, because you're seeing the endpoint intensity as soon as it develops, you can use less power. And all of that translates into more patient comfort. The pulse duration or power setting can be decreased. Higher efficiency means lower power settings, and then turning the duration and the power down helps tremendously in decreasing patient discomfort, especially with PRPs and heavier type treatments. The endpoint when you're doing any visible wavelength photocoagulation depends upon your ability to image that coagulation effect in the retina, and the visibility of the retina becomes a problem. The old systems had dark filters, which made it difficulty, and with the 577 laser allows a reduced intensity very easily. I'll let the guys on the floor talk about the hardware, but it's really amazing. It's so user-friendly and intuitive. You know, I'm a kind of guy like you are, doesn't like to read the instruction booklets. I like to be able to, you know, my evaluation of a new product has a lot to do with how easily I'm able to learn to use it without reading the instruction manual. So if I get a new camera or something, it gets a lot of points if I can figure it out right away. Well, this is a no-brainer. It's just totally intuitive. Everything's where it should be. It's easy to use. It's user-friendly. You have both the desk unit there, a remote with all exact same controls. You even have a foot pedal, a smart foot pedal that allows you to adjust the duration and the intensity of the burn as well. So everything is right where you need it. Very reliable, ergonomic user interface, color touchscreen graphics, just beautifully designed. Even has voice prompts. I haven't used those. And then finally, someone else was asking me today, what, you know, if you're buying a new laser, what criteria would you use? Well, clearly, to my view, there's a tremendous advantage of having the 577 wavelength. That's pretty clear. But also, micropulsing and millipulsing is going to be necessary in all the lasers of the future. So if you buy a laser without the ability to pulse the laser, you're basically buying 20 or 30-year-old technology. We've barely scratched the surface of the advantages of pulsing the laser, and I'll talk to you about that a little bit more. Again, for the elegant design, the hardware, just talk to the people on the floor here. Really nice remote, full panel, has everything you need. Iridex has been a leader in this concept of micropulsing and millipulsing. It's a method pioneered which allows a much finer control of the laser output and the laser tissue interaction. It gives you more control over the thermal effects of the laser on the tissue and facilitates greatly tissue-sparing procedures. And it's applicable to a lot of retinal diseases, all the way from PRP, especially macular diseases, diabetic macular edema and central serous come to mind, and it's been used for many years in glaucoma as well. The concept is, with the old continuous wavelength laser, you dial in 1/10 of a second or 2/10 of a second, push the pedal, and bang, you get this boom, this big thermal effect. And over those 2/10 of a second, the temperature in the tissue starts to go up, 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 up. Remember, you don't have any control over that anymore because you've triggered this event that's out of your control. The temperature goes up, 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 until the laser automatically cuts off at 1/10 of a second or 2/10 of a second, whatever, and then you have the decay. So that's why with a small spot size, it would be easy to perforate the choroid in the macula because you don't have fine control. So pulsing the laser introduces a totally new, novel, clever way to develop that laser tissue interaction. Instead of a single big laser pulse, you introduce multiple small bite-sized pulses. Now each of these small bite-sized pulses behaves just like the megapulse, except the thresholds are a lot less. So you put in, instead of 2/10 of a second, you put in 100th of a second or less. And you do develop that gradient and it decays, but the temperature that it achieves in the tissue is very, very minimal to none. And you control the laser tissue interaction by the pulses set, the duty cycle is set. The duty cycle is usually 50%, the same amount of time on, the same amount of time off, but you can vary that also. But you control the final laser tissue interaction by gradually increasing the power. So you start with a low power, and basically nothing is happening at this level. You turn the power up a little bit more, so you get a little more of a thermal effect in the tissue, but the temperature of the tissue decays back to baseline. You're still not getting an additive thermal effect in the tissue, and it's only when you turn it up to a certain critical high level that you gradually start to produce a thermal effect over minutes instead of over 1/10 or 2/10 of a second, which makes it virtually impossible to perforate the choroid or get one of these surprise white burns that we're also used to with the green laser. And so it offers an exquisite control over the final laser tissue interaction. I think it's a laser without this feature is just already an obsolete laser. So in summary, my clinical impressions, equipment, the elegant design, it speaks for itself. All you have to do is go on the floor and see it. The excellent user interface. The console is very responsive, immediate. Slit lamp adapter, the optical system, everything's super on that category. Performance, very, very good. Less power required to create most burns compared to green. You can consistently obtain the desired goal of getting very mild, light, but effective burns. You can see the burns earlier. The burns are more reproducible. And the clinical benefits, you have more control of the burn. Lighter burns, smaller lesions. The patients are much more comfortable. And finally, important to the doctors, the patients are happier and the treatments take a lot less time. Thanks for your attention. I'll be happy to answer any questions.